Since this morning we have had the opportunity to attend high top level lectures about aging. But many of them has been focused on longevity, making a parallel between aging and longevity. This is, of course, really nice. The problem is that now, currently, we are very close to the human lifespan. Not the fly, not the monkey, not the human lifespan. It's good for all of us to continue thinking in how to prolong longevity. But instead, I think that we have the opportunity to think in the other component of aging, that is functioning. These are data from the European Union, and you can see how, depending upon the country you are living, you can expect to live the 20 additional years in a very nice quality of life, or you can spend the majority of this time in a wheelchair or in any other poor condition. And it's not quite clear that the same mechanisms regulating longevity are regulating functionality. I can give you many examples, but one very easy. You know that women live longer, but they live poorer. And it looks that estrogen is on the physiological basis of these two separate phenomena. The one who allows them to live longer, estrogens, are the ones who make them with a high risk for becoming disabled and with a poor functional condition. So I am going to talk mainly about function, and I will try to also give a more clinical point of view. It would be pretentious for my mind trying to approach the issue from a very basic science approach. I am a clinician, I am a geriatrician, and I am going to put the focus in the problems or in the challenges that arise with the aging of the populations. As we age, we are going to lose what the WHO has named intrinsic capacity. Intrinsic capacity is what we are able to do, disregarding our environment, disregarding the challenges of our environment. Disability is a transitional term. We are disabled for doing some things. For instance, I suppose that 99% of those who are here, we are absolutely disabled for climbing the Aconcagua or the Everest. That's it? That's right? Yeah? But any of you are disabled for crossing the street. When we talk about disability, we need to talk about disability for something. As our intrinsic capacity is going down, the possibility of responding to the challenges of the environment is going down, down, and down. And once we cross a line, we start to experience disability. And this has, of course, a pathophysiological, a biological underground. That it's mainly maximal energy. As we age, our maximal energy is going down and approaching to the minimum theoretical for homeostasis. And as we are losing maximal energy, we are also losing functional reserve. And this is why, as we age, we have lower and lower possibilities to respond to stressors of lower and lower and lower power. And this is why an old woman, 85 years old, with a flu, with a urinary infection, goes to a wheelchair because he was here, and as she has not functional reserve, she comes under the threshold for disability. And this is another problem. We cure the urinary infection, But what we need to recover functioning is functional reserve. So the same thing that has put her under the threshold of disability is what we need for improving, and this is not possible. Of course, this does not happen abruptly. It's happened along the time. And as we lose our responsiveness to stressors, we also lose intrinsic capacity. And as we are approaching this line, we are decreasing the likelihood of reverting our decreases in functional status. So if we wait to be here, we are late, because it's very difficult to revert the condition. And this is why there has been a concept that is the time when we are approaching this line, this threshold, but we are still have some functional reserve. And so it's worthy to detect these people, to intervene on them. And this is the frailty syndrome. From a very intuitive condition, frailty is the interaction between the aging process and some, usually multiple diseases and conditions. Not so much diabetes, heart failure, ischemic heart disease, cognitive impairment, lung problems, arthritis. This means two things. First, aging is needed to be frail, but only being aged, you are not frail. In fact, the major part of older people are not frail. You know that in community dwelling people, around 10, 12 of older people are frail. This means that 88% are not frail. And the second one is that some diseases are needed to become frail, but by themselves, they are not able to produce frailty. Of course, depending upon the interaction between aging, lifestyle, and some chronic diseases, there are different trajectories of frailty. And along the time, there are several changes due to the aging process, but also to the presence of some diseases that in some part of our life, but not before, is able to produce frailty. The same inputs, when you are old, are going to produce different clinical manifestations than when you have 20, 25, or 40 years. And I have tried to summarize this in this slide. You have many mechanisms that can produce oxidative stress and inflammation, but when you are young, these mechanisms are impacting in isolated organs, in isolated systems, producing isolated manifestations. If they are impacting on the brain, you can have cerebral diseases. If they are impacting on kidney, you will have renal diseases. But as long as you age, there is a dysfunction or failure of several of these organs and systems in the presence of a low functional reserve. The consequence is that instead of having single manifestations of single diseases, you are going to have multisystemic functional impairment that is manifested phenotypically as low performance in some physical tasks and in low performance of cognitive tasks. And this is frailty. So depending upon the balance between resilience and the aging process and some diseases, you are going to have a frail older, you are going to be a frail elder or a non-frail elderly. Very recently, it has been shown not only that diseases are risk factors for frailty, but that frailty are a risk factor for some diseases, cardiovascular diseases, cognitive impairment, and some of them, suggesting that probably they share several mechanisms that, depending upon the interaction between them, are going to be manifested in one way or in another. From a clinical point of view, these have consequences, but I think that the main one is this. As you age, the role of disease is lower and lower and lower until becoming near non-relevant, while the role of function is higher and higher and higher. And this is manifested in clinical symptoms, in the pathophysiology, in the prognostic value, and indeed in the efficiency marker, and provoke that the clinical management can be or should be totally different. Which is the relationship between comorbidities and functional impairment? Not really high. These are data from the Toledo study of healthy aging, and this is how prevalent is comorbidity in people from 65 to more than 100. There is not a significant increase in the prevalence of comorbidities. But at the same time, look at the prevalence of disability for ADL, cognitive impairment, or frailty. So it's very difficult to say that these are the causes of this. Second, as a prognostic factor, these are data from Fradea, another epidemiological study in Spain, showing very clearly that as your function is deteriorating, the risk of death at 10 years is growing up. This is adjusted by comorbidities, each big disease, drugs, and many other things. And third, not only for death, but also for use of resources like hospitalization, while Charlson index, is a very well-known index of comorbidity, is not able to predict the risk to be hospitalized. Frailty is able to predict very smoothly and with a clear dose relationship. What about costs? This is very important for sustainability. This is data from Medicare with 6 million, more than 6 million patients. They have divided or classified people in these 6 groups, and these are the prevalence among people attending in Medicare. 18%, 8%, 18, 27, 18, 9. And this is the percentage of costs in Medicare explained by this group of patients. These that are only 8% of the patients represents 40% of the people in the higher costs. And in addition, when they look at the percentage of preventable spending in each category, again, frail elderly is the first one because 51% of these costs are preventable. So I think it's quite clear that if we want to make sustainable our systems, and if we go to provide to other people the best quality of life, we should put the focus on frailty. This has been clearly established about the epidemiologic transition, but it's very interesting to know that we have very low knowledge, we have very few data about what the colleagues have called the clinical transition. How is the impact of frailty in clinical settings? We have huge amount of data from the epidemiological point of view. We have very good data from basic science, but we lack about good data regarding clinical and mainly for interventional studies in older people. So I am going to show you some reflections about what, in my opinion, should be the main focus on research in clinical frailty. I have summarized in this slide. We need to improve our accuracy diagnostic. We should provide clinical pathways. Nowadays, if you go to a hospital and somebody assesses you for frailty and detect frailty, you are frail. Yeah. And what else? No, you are frail. Yeah, what else? No, I don't know, you are frail. Second, we need to improve our therapeutic approaches, because here we are telling that once we are diagnosed as frail, there is not any clinical pathway. If you go to a cardiologist with a chest pain, he first makes you an electrocardiogram. And when he detected that can be some ischemic disease, he decided to make a coronariography or an effort test. No, we do not have this kind of helps in clinical practice. But in addition, we do not have good therapeutic approaches, although we have started to have some research from clinical trials. I am going to put you some examples. These are data from a European-funded study, 5 countries, around 1,500 patients, and this is the prevalence of frailty in clinical settings. Not 10%, 43%. This means that 1 in 2 of the people attended in a hospital is frail, and with a big differences depending upon the setting where you are attended. And in addition, with differences depending upon the instruments you are using to assess frailty, with a very low concordance between them. For those who are not clinicians, you can establish that you have a rather good concordance with a kappa index over 0.6, 0.7. And here, if you can see, any of them, except this, are over 0.6. And when you look, we have followed this person during 1 year, and of course, many of them are able to predict these adverse outcomes. Not all of them, but some of them, but with high differences in the risk. According to Fried criteria, you have 5 times to impair your frailty status 1 year longer, but only 1.3 if you use the clinical frailty scale. And this is also the same for mortality. Frail scale gives you 3.8, Tilburg, there is another scale, 1.9. So this clearly suggests that we are facing different clinical phenotypes of frailty that we are not able to discriminate. In this same regard, we have checked if, for instance, to have or not to have sarcopenia when you are frail, split to different phenotypes. And look at these slides. For death, being non-frail but sarcopenic does not confer any additional risk for death. Only when you are frail, you have at the highest risk for dying, disregarding if you have or not have sarcopenia. But if you are going to assess not death but disability, it's the opposite. Frail people with sarcopenia are at the highest risk, while people who are frail but non-sarcopenic has a very low risk for disability. And this, again, is suggesting that we have different clinical phenotypes. Different clinical phenotypes probably means different mechanisms for being frail, probably means different causes of frailty, and should probably means different approaches, different therapeutic approaches. Imagine, you diagnose somebody to be frail and put in a physical exercise program based on strength training. But this is this is a patient that is in the 30% that are frail but not sarcopenic. Physical strength training programs are not going to be worthy for him. That's right. So if we are able to refine our diagnosis of frailty, we are going to provide better insights and better solutions to the patients. And what about interventions? because I have told you that now you detect, we have proof in this same study that making an intervention during the stay in the hospital improved the risk of death and improved the risk of impairment in basic and instrumental activities of daily living. What about people who are not in the hospital? We have recently published this study, around 800 patients, frail or pre-frail with diabetes. Intervention was a multimodal intervention, physical intervention, but also nutritional when needed, and educational intervention. And we have shown a nice improvement in the functionality as assessed by SPPB. But at the same time, when we have gone to the data in depth, around 35% of those intervention group did not improve. So it looks that 1/3 of those submitted to this kind of treatment are non-responders. And now we are analyzing if there is any characteristic able to identify to those who respond against those who does not respond. So, because it's very important to characterize more precisely, this is what a clinician uses to make with a patient with heart failure, with ischemic heart disease, or with a stroke. But we lack this kind of data in our clinical patients. And finally, there is some role for technology. I think that it's very important to introduce technology in the management of patients that needs integrated and continued care, because the patient needs to be followed along all the system, primary care, specialist care, social care, home care, in order to provide the best care he needs or she needs in any time of their ailments. So I'm finalizing. I think that now is the time for facing what we have called the third transition, that is the clinical transition. It's necessary to break the clinical inertia and change the mind from these concepts to this other one. Instead of cure, we should care. Instead of putting the focus in disease, we should move to function, not putting the emphasis in survival. I used to say that geriatricians never save lives. We try to improve the quality of the life. To do, change to ratio risk-benefit, thinking that our interventions are not long-term. Older people do not have 50 years to experience any kind of benefits. The benefits in older people should be clearly established in 2, 3, 4, 5, 6 years, no longer. We should not be reactive. We should not expect to detect the presence of disabilities or in diseases. We should have a preventive approach, and instead of put the focus in caring the episodes, we need to think always in providing integrated and continued care. This is part of my team, and thank you for your attention.